When Kathy first asked me to speak, she said, can you just talk on what's new in incontinence? And I said, yeah, I can do that. And then she said, can you also do PTNS? Yeah, I can do that. So what I really thought I was going to do is, this is going to be a little unconventional. I'm going to go over some things, but I'm going to talk about some of the things we use in our clinic. We are a nurse practitioner run clinic. We do have a collaborating physician. But since we do everything short of surgery, however we do Botox and InterStim, we pretty much have to be resourceful for our patients because everybody in our clinic doesn't want or need or can have surgery. Everybody is not a good candidate for third-line therapy. So we have to be fairly resourceful. So what I've done today is I've picked up some things that I think are new. I want to talk to you about the newest research and some things that have come up. I was just at the SUFU meeting in Phoenix and got a lot of good information from there. So that'll be the first half. We're going to talk about new things. In the second half, we're going to talk about PTNS. How many of you do PTNS here? Okay, so a fair amount. It's going to be very basic because I was told most of you do not do it. And then after lunch, we're going to do a simulated lab where you can go do PTNS on each other. And it'll be kind of fun. Actually, I think it's important that you do because it's important that you explain to the patient what it feels like. So that's kind of my thing. Ever since I was in nursing school in pediatrics, and my instructor said, I want you to taste that medicine so you can go to that kid and say, it tastes like this. And I said, what if it tastes awful? Well, you have to tell them it tastes awful, but it would be quick. So everything we're going to talk about, believe it or not, I have tried everything because I'm not going to tell somebody, do this, and it doesn't hurt, it's not uncomfortable, anything like that, because sometimes it is. So the trends that we're seeing now are pretty impactful, I think, and that is that patients are wanting fewer visits and there's more home care involved. And fewer visits because, I don't know about in Illinois, but in Michigan, almost every single insurance specialty copay went up to $50 this year. So it's pretty expensive for them to come for an office visit. Treatments aren't so expensive. So, and to get reimbursed for a lot of the treatments we do, we pre-authorize everything. So we pre-authorize Pessaries, we pre-authorize PTNS, eStim, Biofeedback, InterStim, Botox. We pre-authorize everything because if you don't and you get burned, it's really not fun. So I feel like everything is cost-driven. So everything that we do, we have to make sure that we are doing it in a way that it's going to be cost-effective for the patients, but yet cost-effective for us to do it as well. And then we have to look at time. Patients don't have a lot of time. A lot of my patients are elderly. One of their children bring them, and so I have to be cognizant of that. So we keep all those things in mind. So when you're working with your patients, this is nothing new. I think the very first thing, and I always ask patients, what is your goal? Why are you here? I know you have incontinence, but what's your goal? Because a lot of them say, I don't really care if I'm dry. I just want to be able to go out to eat and not have to wet my pants. I want to go to my daughter's house, and most of us are women, and we know that we really complain about when somebody's going to wet on our furniture. It's not a nice thing. And so they're concerned about those things. So what are the patient's goals? And they can be as simple as, I want to just go 2 hours without exploding in my Depends. So those are the really important things. Quality of life is so important with these people. And just because I work in geriatrics, I do see younger people, but it's interesting because I just saw a postpartum woman last week, and she was saying, when I was telling her that this was pretty common, she said, how come nobody talks about it if it's so common? Because anywhere from 33 to 50% of pregnant women will have bladder problems. whether it's for the last trimester or the first month after they have their baby or 6 months or a lifetime. That's how many people have it. And it's true, nobody talks about it at that age. So she was pretty embarrassed. And sometimes people just want to be able to use the right products. And if you don't delve into what kind of products they use, you'd be shocked at how many people use the wrong products. And that's the biggest reason why they leak all over the place. So when you're seeing a patient, of course, we always begin with a very extended history, a physical exam, and hopefully we come up with the right diagnosis. Because how many times have you guys seen patients that were diagnosed as urgent incontinence and came to you on medications and you're like, what? They have stress incontinence. No wonder the medication doesn't work. So diagnosis is the first thing. Physical exam, we want to make sure there's nothing that's contributing, or if there is something contributing to the incontinence or the bladder issues, that we're taking care of that ourselves. So the other thing in our clinic is we do a lot of education. No patient comes to the clinic in any appointment without getting written information. And I say that because as I get older, I appreciate anything anybody gives me in writing. So I know that people will say, oh, can you write that down? Can you write that down? And I'll say, here, it's already written down for you. So that's really important. If you don't have patient education in writing, there's so much free stuff available on the internet. And if there's something in particular that you want, just email me and I'll send you mine. The other thing is focusing on prevention. So if a person comes to you and they have stress incontinence, or they have urgent incontinence, or they have a prolapse, or they just have one thing, dysfunctional voiding, it's not beyond us to teach them everything else about their bladder, because we don't want them to become incontinent. We don't want their prolapse to get worse, and we want them to take care of themselves. We want them to be able to void properly. It's always funny because every patient that comes to our clinic, we teach them proper voiding techniques. So they're like, how come nobody ever taught me this before? And I go, I don't know, because you know, they think that when you're 2 or 3 years old, you learn proper voiding, but you really don't. So those are the things that are really, really important. We focus on good bladder health, and we always look at the future. We treat our patients as patients with chronic conditions, because if you don't, you're going to lose them. Because you know that only 30% of patients who are prescribed a medication are still on that medication a year later. And for several reasons. One, it was too costly, it didn't work, they had side effects, but they never went back to their provider because their provider said, well, I'm going to give you a couple of samples here and let me know how you do. And if it doesn't work, you know, come back. Well, you know, you need to make that appointment to make sure they're coming back. So the Cochrane reports, does everybody know what the Cochrane reports are? They are reports that come out periodically that discuss all the research that's available on any given topic within urology. I guess I don't know if they do it in other diseases or not. But the latest Cochrane report that came out on behavioral modifications came out in 2015. And it's very interesting reading this because it kind of contradicts everything I've been taught and everything I've been teaching people for years. It doesn't mean that we shouldn't still teach those things. It just means that there's not data that supports a lot of it. And the other thing is that when somebody has this problem, they should really know how it contributes to their incontinence. So weight management, there's only one study out there that's about 10 years old that talks about for every 5% of weight you lose, your incontinence will get better. And that's either urge or stress because of that large amount of abdominal weight that is putting pressure on your bladder, either causing urgency or stress incontinence. But the other interesting thing is that as people gain weight, we found that they've developed incontinence. So in your history is a very important question. Have you lost or gained more than 5 pounds in the last year? And then you can pretty much get a history of their weight issues and how they manage their weight. A lot of our patients that come that are overweight or obese have gained weight in the last 1 or 2 years and consequently have developed incontinence. So increased fluid. It's very interesting. I was always taught, you know, void 6 to 8 times a day and drink 6 to 8 cups of fluid. So fluid in, fluid out. So is that really the case? Kind of. Normal voiding is about 6 to 8 times a day. But fluid intake is commensurate with what your bladder will hold, basically. So I tell my patients, you're drinking 14, 16, 15 cups of fluid a day. You're leaking. You need to cut back. But do you need to cut back to 6 cups? People who drink that much will never cut back to 6 cups. They're people that drink constantly. So what I say to them is, it's important that start cutting back a little and see what helps you. But in the meantime, they're being taught Kegel exercises, they're doing urge reduction techniques and all of that type of stuff. So it's important to know that it's not specifically the fluid that is causing the incontinence, it's the amount of fluid that the bladder will hold. In people who have congestive heart failure, they have increased fluid loads all over their bodies. When they lay down, that fluid goes all the way through their heart, their kidneys, and out their bladder. And so it's important for us to know what kind of people those are. Diabetics, they also have issues with fluids and they have issues with blood sugars. And anytime sugar goes out through your bladder, it's going to be an irritant and it's going to cause frequency and urgency. You know, when I was first a staff nurse, we did clinitest and acid test. Does anybody know who that is? Probably not many of you, but we could always predict because that told us that that was a urine test that told us that they were spilling urine. So when the patient comes in your clinic and is diabetic, I hope you're doing a dipstick on all of them, and depending on what time of the day and when they last ate, if they have glucosuria, it's important to note that and what. The other thing is decreasing caffeine. So we've always been taught that caffeine is a bladder irritant. Yes, it is, but it's the fluid load that is really what is causing the irritability. And it is a bladder irritant. However, there are people that can tolerate a pot of coffee. I couldn't tolerate a pot, I don't drink coffee, but I couldn't tolerate a pot of tea. I'd be peeing all day. But, and then there's pop, soda. That is the other killer, but the problem with that is it's a triple whammy for the diet pops. It's got artificial sweeteners, which we know that saccharin and, what's the other one? Aspartame. Saccharin and aspartame are bad artificial sweeteners. The newer sweeteners, which are not supposed to be artificial, we don't really have any research on those, so we don't know. But I do say to them, if you have to have a sweetener, get away from the others and try something different, something that's more natural. And so those kinds of things also, the carbonation and the caffeine and the fluid. So all that, so we have to talk about all those pieces when we're talking about fluid and decreasing caffeine. Smoking cessation, we always thought that nicotine was a bladder irritant. Maybe, maybe not. But the problem is when smokers smoke for so long, they have that smoker's cough. And when you think about the pressure that constant coughing puts on your pelvic floor, it weakens the pelvic floor, and that's how they become incontinent. So they're saying, but I've been a smoker for all my life. Yeah, you've been coughing all your life too, but you've been coughing more since you've been diagnosed with COPD the last 5 years, and that's why you're leaking. So those are the things that we need to teach our patients. And constipation, of course, is pressure on the bladder. Anybody who's constipated that comes in our clinic, we treat their constipation before we can treat anything else to see if that's one of the problems that is inherent in that. And then physical activity and physical forces, people that are big time exercisers, this is what I always say to my daughter, who's not only a physical therapist, but she's a crazy, freaky exerciser. I go, you just wait, you're gonna get incontinent if you keep doing all that exercise. She gets on me when I don't exercise, and I get on her in the meantime. So let's talk about pelvic health fitness. Right here in Chicago, you have the Women's Health Foundation. Anybody know about them? Oh, I'm going to have to tell Missy that you don't know. They run the Total Control program. It's an amazing program. We have purchased the rights in our area for the Total Control program. We've been providing that program for the last, it'll be 7 years now. And we have classes of anywhere from 5 to 9 people. What Total Control does is it helps you control your abdominal muscles, your pelvic floor muscles, and your multifidus muscles, which are your low back muscles. And what the class does is it helps you to separate those muscles and be able to use them appropriately so that you're doing your Kegels correctly, you're doing your low back exercises correctly, and you're strengthening your abdominal core. So it's an amazing program. We have great results. People who have minor urgency or stress incontinence, we put them through that program first before we consider anything else. It's very cheap. In Muskegon, we charge $49 for 7 weeks. And it's a 70-minute program, and they have 50 minutes of exercise and 20 minutes of education. And it's really worked out much better for us. It helps improve their core, their pelvic floor muscles, their Kegels. It helps them sleep. It helps their low back pain. And it also helps their sexual health, which is very good. And it's only for women, but it's for women of all ages. And yoga, in 2014, believe it or not, research was done on yoga and the effects of yoga and how it really helps incontinence. You guys all have seen patients that are anxious and they have this overactive bladder and they're going to the bathroom all the time and you can't figure out, nothing is working for them. You do urodynamics on them and their bladder holds like 400 cc's and you're like, what? So these people have a fair amount of anxiety. These are people that we refer to yoga. And we say you need to take a yoga class to reduce your anxiety, to reduce your stress. It also decreases mood disturbances so that you can tolerate things a little bit better. And how it works is it improves the sympathovagal balance, resulting in decreased inflammation. Inflammation in the bladder causes irritability and can cause incontinence. So that whole body change that happens with yoga is really a very positive result. So let's talk about some incontinent treatment options. Pelvic floor therapy. How many of you do pelvic floor therapy? Any of these? Easton, biofeedback? None of you guys do that? Okay, so you're going to learn something today. So Kegel exercises, everybody knows Dr. Kegel, and he in 1948 introduced Kegel exercises, and believe it or not, it is the mainstay of stress incontinence and urge reduction. It works, it's always worked. However, you have to tell the patient exactly how long do you do it, when are you going to see changes, and can I stop doing it? The answer is you can't stop. So these are pictures of the original, these are the original pictures in his article that shows the perineometer, and it's just like a sphygmomanometer, only it's attached to a device that goes in the vagina, and you squeeze that and you can see the pressure that you're exerting. So that was the first bit of biofeedback, because biofeedback, and we'll talk about that a bit, is where you can see really the strength of your muscles. So he was quite brilliant, I think, because we wouldn't have all this pelvic floor therapy without this original stuff. There's also a format that we use with elderly people that are cognitively impaired or that have had a stroke. When they've lost that brain to bladder, bladder to brain connection, they can't do a Kegel. So if you've ever done a pelvic exam, put your finger in the vagina and said, squeeze it, and they're like, I can't, I don't know how to do that. They just don't have the coordination. So a physical therapist called Janet Hume, a long time ago, almost 20 years ago, 18 as a matter of fact, published this using a ball to do Kegel exercises. So of course, I didn't believe it. So I hooked myself up to Biofeedback, and these are like 6-inch balls. You can get them at the dollar store for $1, and we give them to our patients who need it. Have their feet turn inward, and if you try this, and you can also do it with a double roll of toilet paper. So if we run out of balls, we just have them do that until they can go to the dollar store. And squeeze it. You will see and you will feel that your pelvic floor muscles are contracting. So it's a very good way to get people who are cognitively impaired or otherwise can't do Kegel exercises for whatever reason, have no strength. Works very well. How often do we do it? We do 15 in each position, sitting and laying. And then we have them do quick flicks where they just go squeeze, 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 squeeze 5 times and relax for 10 seconds. Squeeze, squeeze, squeeze 5 times and relax for 10 seconds. I have them do 2 of those at the beginning, 2 of those at the end. When they get tired in between, if they're tired after 6 Kegels, stop. And then do the rest later in the day. The important thing about Kegel exercises, more is never better.
Go back.
Yeah.
Can you fill in the blanks?
Oh, squeeze and hold for 5 to 10 seconds. I'm sorry. I always have them start with 5 seconds. I always have them look at a clock because I can go 1, 2, 3, 4, 5. Oh, that's hard. But when you count 5 seconds, it's a long time. Move up to 10 seconds, relax for 10 seconds, and then do for this, we have them do 15 a day in sitting, 15 a day in laying. Oh, this is an old one, I'm sorry. The standing should not be there. So they don't do the standing one. And then the quick flips. I have them do 4 sets of 5 squeezes in each of the 2 positions. Okay, when I teach regular Kegels, I have them do 10 a day in each position, sitting, standing, and laying. Same thing, start with try to go up to 5 seconds, move yourself up to 10, do it by the clock, and then do two sets of quick flips with every set of Kegels. And the literature is very clear that around 30 is what is good. Because if you let's say you did dumbbells, okay, and you did arm flexes, and you said, okay, so we'll do 15, and then I said, no, do 40, but more is better. What happens by the time you get to 20? I can't do that anymore. So are you really, is it any benefit to do more when you're fatigued? No. So pelvic floor is the same way. So biofeedback, anybody here do biofeedback? Okay, yes. Okay, so biofeedback is done by a trained biofeedback therapist, generally a physical therapist or a nurse practitioner. We do it in our office. The patient must be cognitively intact because you're going to instruct them. They're going to have, you can do it 2 ways. You can put a vaginal probe in. For men, you can put a rectal probe in, or you can put electrodes on either side of their rectum, and then there's a round that goes back their legs. And they just do their Kegel exercises, and they can see how they're doing. So it's really feedback to them. They only compete with themselves. And everybody says, So how strong do we have to get? As strong until your symptoms go away. That's the answer. And if I have this strength and you have that strength, that doesn't mean that I'm incontinent and you're not, and vice versa. So you have to individualize all of this. So the treatments are usually 15 to 30 minutes. We do all kinds of different things. We do short squeezes, long squeezes, we do quick flicks, we do going up an escalator. There's tons of programs. It can be used for stress incontinence, urgency, for dysfunctional voiding, and it can be used for vaginal spasm because there are relaxation programs and techniques that you can use for that as well. I also see post-prostatectomy men in our clinic. I don't see men unless they have a primary urologist because we don't have a urologist in our office, so I don't do primary urology because I'm not going to do biopsies. I'm not going to do any of that. So, but we do a lot of post-prostatectomy incontinence for these guys. And again, their prescription is the same. 3 sets of 10 reps can help them. We usually see biofeedback about every other week for about 2 or 3 times, then every 3 weeks, then every month. Because the important thing is not to have you be their crutch. You need to make sure that they are doing their homework. Because when they stop, their symptoms will come back. So pelvic floor stimulation. Anybody do that? Okay, more, good. Okay, so that's stimulated by generally a vaginal or rectal probe. There are external pads that you can use for stimulation. I've never had good luck with those, so I don't use them. The probe has electrodes along inside of them. So, and you put the probe in, you increase the stimulation until the patient is okay with it. It should never hurt. And what it does, and then you just turn the program on, and it contracts the pelvic floor. And what it does is it contracts the whole pelvic floor, and it works the muscles a little bit higher than just the surface muscles. So it does a much better job than just regular Kegels. And you get better faster with E-stim than just doing regular Kegels. It's expensive. There's high copays in Michigan. So we do it. We do a fair amount of it, but not as much as we used to because it used to have very good coverage. And it was very nice for people that just want to get better. People who have incontinence, they want it gone tomorrow. But unfortunately, it didn't just start yesterday, so that's what I always have to tell them. So E-stim and biofeedback is a very interesting treatment because if it's too expensive for them to come to the office, or you don't have the expertise or the machine, because the machines cost about 15 grand. That's how much they cost the last time we bought one. And and the patient has to come back. We have people that come to us from up north, and they're really, somebody's coming from 60, 80 miles, 100 miles away. We don't want them to have to come all the time. So we look at home units for them. So this is Intone. Anybody know what Intone is? Okay, well, like I told you, I've tried everything, and now there might be TMI here, but I have a normal vagina, and I still have my uterus, and I'm still sexually active, so I have an okay vagina. This thing is really big, and it's uncomfortable. My partner, who's half my age, I said, Jen, you need to try this because I don't know, I can't get comfortable with this thing. And this came out first, I think, like 2 or 3 years ago. She tried it, and she had cramps for a day after it. But anyway, there are physicians who love it, who use it for their patients. There are 4 different types. So this is a picture of the one we have. you put it in the vagina, and you can actually, you see how big that thing is? You can actually pump it up to fit in your vagina. Well, it fits in your vagina. And then the little, wait, where's, I know there's something here. These right here, when you squeeze this tells you how well you're doing. And this, that's for the biofeedback part. For the stimulation part, this is the number that you're stimulating at. And so it's not complicated, but my older people couldn't do it. It took me a while to figure it out. So I don't even try it with them. So, and they cost anywhere from $199 to $799. Generally not covered by insurance, but again, if you want a home unit, this is the only, well, no, this is not. We also, yes, it is. It's the only home unit that does biofeedback and e-stim. There are units that do just e-stim that are much cheaper and generally covered by insurance, and I'll show you a biofeedback unit. So the sessions with this are about 12 minutes long, and you have to do them 6 days a week. Now here's the clincher. They'll tell you there is a money-back guarantee if you're not better in 90 days, but this also has memory. So when you say, I've done this, and I am no better, they look at your memory and you say, Leslie, you've only done this once this week, twice that week. You didn't follow the protocol, you don't get your money back. So there's different levels of this. This is the most expensive one. You can also get a clitoral stimulator on the end of that thing. It's got little claws like this, and it's just, that's the $199 one. And then you can get one that's just a stimulator. And then there's one that's smaller for a man, but it's still not small enough because it goes in their rectum. And so I'm just saying, you know, there's no in-tone rep here, is there? But I've told them all this stuff myself anyway because they wonder why we're not using it. So that's why, because we do use everything we sell. So PeriCoach just came out a couple years ago. This is just a biofeedback system. I like this system for a lot of reasons, but it's not good for my patients because they wouldn't know how to set this up on their phone. You need a smartphone to set it up. It's only biofeedback. So when you look at this, this is their biofeedback part. It's their screen. And I like this because it's the same sort of peaks and screen that you get when I do biofeedback in the office. And people get really competitive with my machines. And so what I was doing is I was getting competitive and I was like, wait, I do Kegels every day. I should be better than that. But this probe is, it's comfortable and you can do it sitting or laying or standing even if you wanted to. It tracks your progress and it provides guidance for you. And this too is recommended 3-month usage, 4 to 7 times a week for the best results. And it's $249, but there's a lot of literature on it, and I do like this product. My partners use it for their younger patients. This is perfect for a postpartum person with stress incontinence. Pessaries. Anybody do pessaries? I know some of you, lots of you. I love pessaries. When I first learned to do pessaries like 20 years ago, so I was a lot younger. So just think of yourself when you're 40 years old and you go to this week-long workshop and the instructor says, okay, now you are all going to fit yourselves with pessaries. I'm like, I'm not putting one of those in me, you know? So yes, we all fitted ourselves with pessaries. And you find out that the first time, well, you find out how to fit it because when she tells you how to fit it and then you don't actually do it the right way, you find out that now you have to get it out. And so how are you going to get it out? So you learn different techniques. because she sends you into the toilet stall and says, okay, so you think you're only a size 2? Take it, put it in, see what happens. Oh, it's easy going in. I can't get that thing out, it's a 2. When you are teaching people to take their pessaries out, remember, they're going in this way and trying to get their finger to get that out. You're going in this way and just pulling it out. So it's a whole different world for them to take care of their pessaries. But we do a lot of pessaries. I probably have about 350 patients with pessaries. And we use almost all of them. I don't use the inflatable ball. It's not cleanable. It doesn't work. It hangs out. It's awful. And I've never seen it to work. I use cubes before I use that. And the type or size is based on the width of the vagina, the depth of the vagina, but you also have to keep in mind the opening of the vagina. Some people have small little openings, and then you go inside and it's like the cave of all caves. And you're like, holy smokes, what am I going to do with this lady? But we manage somehow. We'll find one that works for her. So, you know. I have this lady, you would love her. She's 4'9", and she's 82 years old. She has a ring number 7. Who knows how big that is? It's this big. You would never know it. So I think she's always a nice little surprise for when my new nurse practitioners started, because she's been a patient of mine for 10 years. I always let them do her and let them think about what she's got. And I go, just go in there and feel and see what she has. And they're like, oh, how'd you ever get that thing in there? So anyway, so there's other vaginal devices. There are cones, weights, and balls. Now, these have been on the market for a long time. When I first started as a new nurse practitioners in the early 90s, I had a patient who saw this in the paper. She came in with her husband, and her husband said, can I make these with my fishing weights? And I'm like, I guess you could. I'm not a fisherman, so I don't know. So he did. She used them because at the time they were $90. They've gone down in price. They're only about $25, but they run $25 to $90. There's no research on them, so there's no reimbursement for them. But people still use them. You just stick them in your vagina and walk around, and just, if it doesn't fall out, you go to the next size up. And you just, until you get strong. I don't know anybody that it's actually fixed their problem, but it might. So this is the FemSoft. Anybody ever use these, see these? Okay, these really hurt. So I'm just saying. This is supposed to be like a urethral plug, and it's supposed to work for people who leak only with exercise, that type of thing. It's a one-time use. It can only stay in up to 8 hours. It has to come out. It really hurts, and they're sized. So, you know, if you put the wrong size in at the beginning, you'd be hard-pressed to put any other size in to see if it works. The biggest problem with them is infection. They're not covered by insurance either. So, but they are on the market, and we have them in our office, and I offer them to my exercise freaks that think they have to have this, and I have nobody who likes it. And I think they've been out a long time, so 7 or 8 years maybe. Then the Impressa. Anybody know about the Impressa? This is the newest addition to all our little things. So this is sold over the counter. This, you can buy a fitting pack. So we bought a fitting pack, and you get 3 sizes and 3 of each in the fitting pack, and there's 3 of us. So I said, okay, we're going to go for it. So we did it. And they go in just like a tampon. So they have a plastic insertion device, which is comfortable. It's not uncomfortable. And it's just like a tampon. So you know, if we wear tampons, If you don't get it up all the way, it's going to hurt like the dickens. So you put it in, and then, I mean, I'm not incontinent, so I don't know if it causes people to not leak, but when you pull that sucker out, it hurts. I'm not even kidding you. So in the inside are like silicone tines. We've taken this apart and I show people, but I do have patients that use it and like it. So I would always, if somebody doesn't want to use a pessary because they are just exercise people, but I talk my exercise people into, why don't you just get a pessary and just put it in when you go work out? It seems so simple to me. So if they don't, I just recommend this. They can stay in for up to 12 hours, but holy man, I think that you'd have some dry mucosa after 12 hours. So I tell them just to put it in while they're exercising and then to take it out. So you didn't think we were going to leave you men out, did you? So this is the latest plug. When I first knew about plugs, I had a metal one, and it's a big one like this, and it just goes over and it just clamps down. So what was happening was people were putting that on and leaving it on longer than they were told they could leave it on, and they were getting problems with their penis and urine problems and voiding problems and everything. So they came out with this cushy one, and I suggest this to the men. I've had a farmer and a hunter that used it while they were doing e-stim. And they said it was very helpful and not uncomfortable. And so, you know, and I apologize, I had the whole bag of goodies, and it's in my other car, and I forgot it because I have all this stuff. I wanted you to see it and play with it. So this one is more comfortable than the metal ones, so I would, you know, recommend this. But they can only be on for short periods of time, not long periods of time. I don't even like my men to use them overnight. I love condom catheters because I see a lot of Parkinson's patients. In the middle of the night, they freeze, they can't move, they can't grab a urinal, they can't get up on the side of the bed, they can't sit on a commode, and they can't walk to the bathroom. So they are bothering their either bedmate or their caregiver or whatever, or they are wetting the bed. And so, how many of you use condom catheters? Okay, I mean, do you like them? No? Okay, I think if you don't like them, it's not the right size or the right brand. Now, you know, you have to talk to people. It's not like a one-time thing. So it's not like, put this on tonight, it'll feel great, you'll be perfect, and all that. So I just had a patient that we went through 3 different kinds, 2 different sizes, and now they come short and long. And I don't like the short and long because my older guys, they only go for the shorts. And it's important to shave their pubic hairs around it so it doesn't get caught. But I use Coloplast. That doesn't mean that's the best, but I think it is. I think the adhesive is the best, and it doesn't come off. It's connected to a night bag. I don't let my patients use it during the day because they'll just get dependent on it and stop voiding. So I think that's the biggest reason you don't want them to use it during the day. You want them to continue to void. And they do great with these. So there is a sizer. So you just put the sizer on the penis, and that'll tell you what kind to use. You know, undergarments collection devices are really important. And the reason that they're so important is because almost everybody uses the wrong kind. They either use things that are too heavy, things that are too light. They use menstrual pads, and you know that menstrual pads have metal fibers in them. So if you have a patient that has dermatitis from incontinence, the first thing you want to ask her is, what kind of pads do you use? Oh, I use Kotex because they're the cheapest. Well, they're not the cheapest because now you have this problem. So, and they're very irritating, especially to older women. So make sure that you find out what they have. I'm not a pad fan. I don't want my patients using pads at home if they don't have to. So they go off at home, then they go off at night, then they go off if they're comfortable when they go out. But I also have them use the least thick pad that will take care of their problem. So we need to consider functional incontinence as well. We always need to think about cognition, mobility, comorbidities, and sensory deficits. Because these are the things that are going to make or break your success. Sorry. Now, when I am doing behavioral therapy, when I'm doing medications, I'm doing third-line therapy, I always have to take these things into consideration because you know that there are patients that you cannot cure or even make better. And you also have to employ a caregiver. So that's always helpful. So I just want to briefly go over medications. I'm not going to go over them. You all know them. But you know, we use every medication in our clinic because they all have their good things, their bad things. So you know that none of these oral meds can be crushed. Oxybutynin has the highest amount of side effects and should never be prescribed for anyone over the age of 65. The Beers List came out saying it's a dangerous medication. We start our elders usually on trospium. If they have to have a generic. Vesicare has the least amount of side effects, so that's one of our go-tos. If somebody has urge incontinence and urge fecal incontinence, I will always start them with Enablex. And the reason is because they have the highest percent of constipation side effect, 28%. I don't know if you know, but when Enablex darafenicin came out, it was supposed to be for IBS. So it is a great drug for people who have dual incontinence, and about 30% of people do. So that's really a good thing. The only other thing about trospium that I didn't mention, it has to be given on an empty stomach. If they take it with food, it is not going to work for them. So, and then there's Mirabegron, Mirabetril, the best drug ever. However, it works differerly than the anticholinergics, the antimuscarinics. It works on storage instead of on irritability and on the bladder wall. But it's a good drug for the elderly. I never give 25 milligrams. I always start at 50. Their literature states that if you start at 25 milligrams, it takes 8 weeks to find out if it's efficacious or not. If you start with 50, it takes 2. So I always start at 50. There's really no contraindications. If they have erratic blood pressure, I stay away from it. So anybody who's on 3 blood pressure meds, a diuretic, an ACE, a calcium inhibitor, and a beta blocker or whatever, I don't give this to them. I don't want to have to worry about their blood pressure. And of course, with all the drugs, it's not recommended in severe stage 3 or 4 kidney disease. So let's talk about third line real quickly. We do all third line therapies. They are all very effective. Botox now has literature that they are more efficacious than sacral nerve stimulation. We do very limited that because of that, because it's very, it's easier to do it on our patients. We've had very good luck with Botox. We've probably done 50 of them, and we've only had one patient that has had to cath herself, and she only cath herself for a week, but she was predictable too. Interstim therapy is still the go-to for people that have really, really bad disease. And when we do InterStim, we'll tell them, you know, we've tried everything else, and I can't promise that this is going to help either, but if you can decrease the amount of times you're in the bathroom, decrease the amount of urine that you leak, it's a good thing. And then, of course, PTNS. PTNS is the only third-line therapy that is non-invasive. I mean, I don't call a 34-inch gauge needle very invasive. But there's very interesting things coming out with percutaneous tibial nerve stimulation that are in trials. There is an implantable device. There are home devices. There are self-adhesive devices. And there's other ways, but I just can't talk about them right now. So in summary, creativity, the most important thing when you're trying to deal with incontinent patients. Be considerate of patients' time and money when you're looking at things. Hammer home behavioral management. Incontinence is a chronic disease, so reinforce lifestyle changes, behavioral interventions, and compliance. Follow up, follow up, follow up. So I'm going to just quickly talk, I have about 10 minutes left, about PTNS. It's just a basic overview. So for those of you that want to come and practice, we're going to have a practice session after lunch. So we're going to define PTNS. We're going to talk about its usage within overactive bladder. We're going to identify the right patients. And I'm convinced that any third-line therapy, it's the identification of the right patients that makes you successful. So what is PTNS? It is a minimally invasive neuromodulation. The neuromodulation, the physiological process to influence activity in one neural pathway through synaptic activity to another neural pathway. So it goes through the tibial nerve to the sacral plexus in the spine in between S2 and S3, and then goes to the bladder, and that's how it works. So it's indicated for refractory overactive bladder. However, and that's urinary urgency, frequency, and urge incontinence. We have used it, obviously, when medication and or behavioral modifications have failed. But we also use it for patients that all those things are contraindicated. So I don't know, Bill, does the literature still say that you can't use it for in pacemakers and cardiac defibrillators?
It does. If it's cleared by the cardiologist, it can be clearance, but yes, it's definitely.
Yeah, I don't do it because I don't have any doctors in my clinic, and I've called 911 enough in my clinic. I don't need to have that too. So that's the only time. And then, of course, if they don't have the right kind of ankle. So when you choose, look at medical necessity, that they were a behavior failure, a medication failure, they had intolerance to medication, or contraindications. Make sure that they are going to be compliant. Make sure they understand what the process is. Review the contraindications with them. Insurance coverage is very good. Medicaid, not so good in Michigan, but still, you know, it's, if the patient needs it, they need it. So this is a CPT code and the diagnosis code. And we have patient-informed consents that you can have a copy of when you come over in the other room. I use it on everybody. They get a copy. We have a copy that we scan into our EMR, and they're quite nice. So this is the equipment. You have the lead packet, you have the stimulator, you have the connector, the needle, and the grounding device. So make sure that you have a comfortable place for the patient because they have to sit still for 30 minutes. Make sure the leg is supported. We would have put this leg on a pillow. And make sure the insertion site is easily accessible. People ask, does it matter right or left? I like doing their right foot because I'm right-handed. If you're left-handed, you'll like doing the left foot. So when I come in a room and somebody's got their left foot open, I go, ugh. So let's look at the PTNS insertion location. Very simple, and we'll go over this. It's on the inner leg right here. So you go to the, the malleolus right here, the middle of it, 3 finger breaths up, and I go halfway between that spot and the Achilles tendon, and that's your spot. There's your tibial nerve. So when the needle's in, you see that the needle is not piercing the nerve, because when you hit the nerve, they'll let you know it. So you either want to be on top of the nerve or next to the nerve. And the needle goes in a 60-degree angle. It's a 34 gauge needle. It's really not that, it's not even, it's easy. Okay, so, went over that. So the first thing, you clean the site with alcohol, place needle. Needle's in a guide tube. So you place it where you want, put it at a 60-degree angle, take that little pink stopper off, and then just click. I click like this. I don't push it in. When you push the needle in, they can feel it more. I just give it a little flick, and they're like, what just happened? And so they really don't feel this much. And then you can take the sheath off. Now, I'm going to do one disclaimer here. All these slides have hands without gloves on. We use gloves in our clinic because we're required to. So I'm going to say to you, use gloves. So you just insert the needle. So question I always get is, how far do you insert the needle? You know, it depends on the ankle. So a thin ankle, you want to just anchor it, because if you push that needle in and you hit the nerve, they will never come back. I've had my nerve hit, and it doesn't feel good. So then once you're in a little bit, I always put my other finger right above the needle here, and I just kind of palpate that, and I just turn the needle while I'm going in. They never feel the needle go in, never. So then the insertion, it says here 2 centimeters or half of the bottom portion. A half of that can be a lot sometimes. So it's not always a half. Then you connect the lead wire to the device. And then you put the adhesive piece right there. And some people, make sure you clean that off with alcohol. Some people come with their feet all lotioned up, and then that's a problem. Then you attach the needle, the electrode clip. Now, I never put it on top here. I always put it on the bottom here, right at the junction. You'll see the needle is a little bit different. It's just a plain needle here, and then there's wires that run around there. And then I always put it in the middle there. And then this is how it works. So you're stimulating, it goes up, there's the sacral plexus. There's sacral plexus. There's your nerves that go to the bladder. So the first thing you're going to do is enter test mode. You press the yellow button and hold it for 2 seconds, and test will come up there. Then you want to adjust the current. This is up, this is down. You want to go slow. You don't want to go click, click, click. Do you feel anything? No, because you're going to click, 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 and they're going to pull their foot away. So you have to just click it, see if you get a response, click it again. And we'll go over that. So you're looking for a motor response. You're looking for the toes to either fan or to go like that. You may not always get that. That's an extreme response. Sometimes you'll get a toe that just flickers like this. What you have to look for is to make sure that you know if they're moving their toes themselves or not. That's the key. So then when you've gotten to where you want to go, you push the green button, hold it down, and then start. If you have pushed this and you push this again by mistake, you've lost that lead. So you're out $65 and start over again. So just be comfortable. Make sure the leg is supported, and make sure they have some way to identify you. We just have one of those little bells, ding, and they can call us. So the therapy is 30 minutes. You'll see this says end on there. This is the, well, that goes through that. I'll go through all those little things. So when you're finished, turn off the stimulator. You'll see end in there. You can turn the stimulator off by holding that down. Unhook the connector take the needle out, throw it in your needle bin, and again, use gloves. And then take this out. This is all, you throw this all away. Okay, so turn the stimulator on here. All right, 2 seconds. This is the power on, power off. This adjusts the current. This is the test mode is yellow. Therapy mode is green. Stop is red. So when you're going up, 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 and you don't get a response and you want to put the needle in a little bit farther, you push stop, not green, stop. And then it'll take you back to 0, and then you'll start going up again. So when you look at the screen, this is the battery level. I never use it unless it has 4 bars. When you get your box of leads, it has a battery in it. So you always have enough batteries to change it. You also get a little bit of tape. I like to tape my electrode because I don't want it flopping around. So if you get this little bomb, there's a lead wire function, and that lead's done. So whatever you did doesn't work. So the current setting, it'll come up right here, and it'll go up from 0 to 9 to 18. This is the current. This goes on when the device goes on. So test mode goes up here. That's test mode. Therapy mode. This is the running time. You'll see that right next to your number that you're stimulating. And when therapy is completed, it'll say end right up there. So documentation, this is really the end. I have all my documentation. Anybody who wants documentation, if you don't have EMR, but if you have EMR, I have Athena, and I made my own documentation, and we just click things in the box. That's the most important thing because you have to have all those parameters. But if somebody wants something, I have it. So make sure you get informed consent, pre-auth. Make sure you have voiding diaries before and after. If you don't have a PTNS policy, I can give you that as well if you want it. And patient education. And I wanted to tell you about, oh, look at that. Don't. Oh, uh-oh. Don't look at that anyway. I have to give you I have the names of your reps, either Bill or Mark. They're on a piece of paper out there, and their phone number if you want to call them. So, but I wanted to tell you, where's Katie? She had the outline, the patient education handouts. Did she have these patient education handouts? I sent them to her to copy. She was going to copy them. No? Oh, okay, we'll put them online. Okay, you guys are the very first people to hear about this patient education program. It is amazing. Not that I helped with it, but it's amazing anyway. Cogentix put this together. It was their idea after I complained a lot. This is every week. It tells you what patient education piece to go through. The patient, you can go to myptnscapitalized.com, and it will come up with this patient education for patients. And within each week, there's also links to other things. Like when they talk about fluid management and bladder irritants, there's a link that will tell you what all the bladder irritants are. But the best thing about this is that you're going to get each week in writing too, that you can make copies of and just hand them to your patients that don't use the computer. So it's amazing. So if you have questions about that, and if you have any other questions, I'll see you after lunch.